So now let's discuss the herpes virus family in more depth. Here are the 8 clinically relevant herpes viruses. Do you remember, are these viruses DNA or RNA viruses? These are DNA viruses. Very good. And are they enveloped or naked? They're enveloped viruses. Very good. And where do they get that envelope in the infected cell? They get it from the nuclear membrane. Very good. So let's start by talking about herpes simplex 1 virus, or HSV1. HSV1 is acquired through salivary or respiratory transmission. The first time someone is infected with this HSV1 virus is called the primary infection. During the primary infection, there is a more severe systemic reaction to the infection, including symptoms such as fever, chills, malaise, and even regional lymphadenopathy. Once the primary infection resolves, the virus becomes latent in the trigeminal nerve ganglia. Once it is in the ganglia, it can hang out there and wait patiently, and then it can reactivate and cause recurrent infections during periods of stress or in immunocompromised states. And this is when the virus actually travels down the trigeminal nerve to the lips and presents as herpes labialis, or more commonly known as cold sores, as we see here. Ulcerations of HSV1 recurrent infections are vesicular. The recurrent infections are vesicular lesions, keyword, meaning that they are fluid-filled pockets that are teeming with virus. They're fluid-filled and they have lots of virus in that fluid. The virus can also cause ulcerating lesions of the eye, causing keratoconjunctivitis, as well as the hand, known as herpetic whitlow, which we see right here. You can see the ulceration right here. So remember, the virus can cause blisters and ulcerations on the eye, lips, and hands. Very good. And finally, do you remember what life-threatening infection can be caused by HSV1? Remember, if the virus gets into the central nervous system, it can cause temporal lobe encephalitis, which presents as fever, headache, seizures, and even altered mental status. If you ever see MRI changes in the temporal lobe on step 1, you should be thinking about herpes simplex virus. HSV2 is transmitted by sexual contact and is the main cause of genital herpes. Once again, this virus leads to vesicular blisters that are teeming with virus. When they are irritated or break, they can form very painful ulcers. So when HSV2 is not at the surface of the skin causing these painful ulcers or vesicular lesion, it remains latent. And do we remember in which ganglia this virus remains latent? In one of the sacral ganglia. Very good. The virus can reactivate, similar to HSV1, and lead to recurrent genital lesions. And do we remember what drug can be used to prevent these recurrences? That's the acyclovir derivatives, valacyclovir, or just acyclovir, or famciclovir. Very good. It is important to remember that HSV is an important Torch's infection that can cause congenital defects when it is passed from a pregnant mother to her developing fetus. And do you remember what it causes? It can cause a nasty conjunctivitis, and it can cause that very dangerous temporal lobe encephalitis or meningitis in the newborn baby. Cesarean section is indicated for mothers with active HSV infections to prevent this transmission. Now let's discuss varicella-zoster virus. The varicella-zoster virus causes 2 similar diseases that are separated by patient age. In children, it can cause the infamous chickenpox, and in adults, it can cause shingles. In chickenpox, children get a mild flu-like illness with characteristic skin lesions described as dewdrops on a rose petal. I know it's difficult to see in this image, but we can see that there are sort of chickenpox lesions throughout the body, and they appear as multiple lesions that are at different stages of infection. We can see some papules, we can see some vesicles, we can see some pustules, some are ruptured, some are not. These typically resolve after a few weeks. Once you acquire the chickenpox, the virus stays in your system for life. The virus remains latent can stay in the trigeminal ganglia, or it can stay in dorsal root ganglia throughout the body. When it reactivates, it can lead to extremely painful vesicular skin lesions known as herpes zoster or shingles, as we see here. This usually happens in elderly or immunocompromised individuals. The key to diagnosing shingles is to look for painful vesicular lesions in a unilateral dermatomal distribution. It is important to know that these lesions do not cross the midline. Shingles is a very painful lesion, and when you have the rash, and it can also be painful after the vesicles have resolved. Let me say that again. Shingles is very painful when you have the rash, and it can also be painful even after these vesicles resolve. This is what is called post-herpetic neuralgia. Next we have the Epstein-Barr virus, or commonly known as EBV. EBV is best known for causing infectious mononucleosis, more commonly known as mono. Mono is also referred as the kissing disease because it is commonly transmitted through saliva in teenagers between 15 and 20. In mono, we will see patients with fever, fatigue, they'll have pharyngitis, they can also have cervical lymphadenopathy, as well as hepatosplenomegaly in severe cases. If you ever see a patient on the boards, if they're 16 or 17 years old with fatigue, sore throat, and cervical lymphadenopathy, you should be immediately thinking of mononucleosis. So as a physician, why do you have to advise your athletes who have mono to avoid contact sports? Well, it can lead to a splenic rupture, which is a life-threatening complication in patients with mono. So now talking a little bit about the immunology. What important cells do EBV infect? EBV infects B cells that are CD21 positive. We can remember that EBV infects B cells. It's also important to remember that CD just stands for cluster of differentiation, and all it is a cell surface receptor that is used to identify different immune cells. So now how do we diagnose an EBV infection? Well, diagnosis can be made in one of two ways. You can see an atypical lymphocyte on blood smear, or you can use the monospot test, also known as the heterophile antibody test. Here we can see a peripheral blood smear that shows a atypical T lymphocyte. It's an atypical T lymphocyte. And how do we know that this is atypical? Well, typically, lymphocytes are round cells, and their nuclei take up most of the cell's cytoplasm. We can see here that this cell here is certainly not round, and also there's a lot of excess cytoplasm surrounding this dark purple nucleus here. So it is certainly not a round cell, and the nucleus doesn't take up the entire cell's cytoplasm like a healthy and normal T lymphocyte would. So something to remember is that EBV infects B cells. Remember, it infects B cells through the CD21 receptor, but it causes the T cells to become atypical. It is a commonly asked question on the boards. They'll ask, what are the atypical lymphocytes in an EBV infection? Are they the B cells or the T cells? Remember that although EBV infects B cells, the cells that are atypical on a blood smear are actually the cytotoxic T cells. This is because the T cells are activated in response to the B cells that are infected with EBV. So this lymphocyte here is one of the activated cytotoxic T cells that is reacting to the B cell that is infected with the virus. So now let's go back to another way to diagnose EBV, and that is the monospot test. The monospot test takes a patient's serum, which remember is their blood without red blood cells. So it takes the red blood cells out and mixes the serum with sheep or horse red blood cells, and it looks for agglutination. Do you remember what agglutination is? Agglutination stands for clumping of particles, like glue. Agglutination. Agglutination occurs when an antibody is exposed to an antigen. Those come together and agglutinate, forming a complex, an antibody-antigen complex. In patients with EBV infection, their immune cells produce heterophile antibodies that bind to antigens found on sheep or horse red blood cells. So you can imagine that when you add the serum of a patient infected with EBV to a vial with horse red blood cells or sheep red blood cells, agglutination occurs, and that is recorded as a positive test. So just to review, when you take the serum out of a patient who has EBV infection, that serum, when mixed with sheep or horse red blood cells, leads to clumping of the particles, also known as agglutination, and it is read as a positive test. Note that the EBV virus remains latent in our B cells and will be there for life. So we can see this is a common feature of herpes viruses. They establish latency in either nerves, such as in herpes or varicella, or in blood cells, as seen with EBV. It is important to remember that EBV is also associated with Burkitt's lymphoma, a type of non-Hodgkin's lymphoma. So if we think back to hematology, what translocation is associated with the development of Burkitt lymphoma? Remember, that's a translocation from 8 to 14. And we can remember that by remembering 8 looks kind of like the B in Burkitt. Very good. The tumor in Burkitt's are endemic to Africa and usually are seen in the face, as we see in this child. The solid tumor right here is actually composed of mainly malignant B cells. And that makes sense because we remember EBV infects B cells through the CD21 receptor. The other cancer associated with EBV is nasopharyngeal cancer, often seen in populations from Asia. Now let's just talk about cytomegalovirus, or CMV. Key things to remember about CMV is that it's also one of the Torch's infections. In newborns, it can cause a petechial rash, seizures, hearing loss, and other CNS deficits. In adults, CMV causes a variety of diseases, especially in immunocompromised individuals. In immune-competent individuals, CMV can cause a similar disease as EBV in mononucleosis. Do you remember some important symptoms that you would see in a patient with mononucleosis? You would expect to see fever, fatigue, pharyngitis, painful cervical lymphadenopathy. And the way you would differentiate CMV from EBV is with the monospot or heterophile antibody test. And do you remember how EBV and CMV would differ on this test? Well, CMV would cause a heterophile negative mononucleosis, while EBV would be heterophile positive. They like to test us on the board, so I would remember this. In immunocompromised individuals, CMV causes retinitis. The way we can remember this is by thinking of it as cytomegalovirus. Remember the cyt as a mnemonic to remember that it can cause a retinitis. It also causes pneumonia, colitis, esophagitis. It is transmitted sexually, by contact, saliva, urine, or by transplant. CMV is a very common virus, with some studies showing that up to 60% of the United States population has been exposed and could be infected by CMV. But do you think that 60% of the population is suffering from a CMV colitis? No, I highly doubt that, which is why it is important to remember that the virus really only affects people who are immunocompromised. Here's a classic pathologic tissue specimen of CMV infection. The diagnosis is made by visualizing infected mononuclear cells with an owl-eye inclusion, as we can see right here. This is a high-yield image and is often seen on board examinations. Human herpes virus 6 and 7 cause a roseola syndrome, which is characterized by high fevers, followed by a diffuse red macular rash, and it usually starts on the chest, back, and abdomen, and spreads to the extremities. And how does this differ from measles and rubella? Well, remember, measles and rubella viral rashes start on the face and then go down to the trunk and extremities, while in HHV 6 and 7, it starts on the chest and then spreads through the extremities. Another important feature of the rash is that it is not itchy or uncomfortable, and it typically resolves after a few days. Human herpes virus 8, or HHV8, causes Kaposi sarcoma in HIV patients, and this results in angioproliferative lesions, as we see in this image. If we think back to bacteriology, do you remember which bacteria causes a disease that looks similar or mimics Kaposi sarcoma? The disease I'm referring to is bacillary angiomatosis caused by Bartonella henselae. In order to know for sure what is causing a lesion that looks like this, is to do a skin biopsy. Before we move on from discussing herpes viruses, let's go over how we identify herpes simplex virus infections. Remind me, what infections are caused by herpes simplex virus? Well, usually HSV1 causes blisters and ulcerations of the mouth, hands, and eyes, while HSV2 causes blisters and ulcerations in the genital region. Very good. There are 3 ways in which we can diagnose herpes simplex virus. We can diagnose it with a viral culture, a PCR, or a Sank smear. Viral culture is used to culture lesions of the skin or genitals. PCR is used to identify HSV in the cerebrospinal fluid. The boards like to ask you about the Sank smear and HSV. And remember, Sank is a buzzword for HSV infection. The Sank smear identifies HSV1 or HSV2 or even varicella by looking for multinucleated giant cells, as we see in this image. Multinucleated giant cells are formed from the union of several cells such as macrophages. So just think, thank heavens you don't have herpes. Another way to identify HSV infection is to look for lesions on a skin biopsy that are called intranuclear Cowdrey inclusion bodies. These are pathognomonic for HSV or VZV infection. Flash quiz time. Can you tell me, how does the monospot test differentiate between EBV and CMV mononucleosis? Well, remember, EBV has a positive monospot test, while CMV has a negative monospot test. Remember, the monospot test takes the patient's serum, their blood without red blood cells, and mixes it with red blood cells from a sheep or a horse, looking for that agglutination. If there is agglutination, the test is positive, and if there isn't agglutination, the test is negative. Positive means EBV, negative means CMV. Very good.